Ma'am. Thank you for the kind introduction. Welcome all for this first session in this conference on a Saturday morning. Appreciate your presence and these are my disclosures and I do not have any conflict of interest for this talk. So the debate, the question is the glycemia control remains of paramount in diabetes management. Is it relevant at this 2025 is the question, and I am speaking for that, which I feel is something like this, where I given a task with which is obvious. It says water on road during rains. So it is something like that where I'm talking about, and with my good friend Dr. Suresh. Of course, if you see this pre-insulin era and insulin era, the target always has been the glycemic control, which can clearly result in this life expectancy over a century. So this is my first slide, which talks about the pre-insulin era as well. So when you revisit the basics of diabetic pathophysiology, the prolonged hyperglycemia is the root cause which triggers this inflammatory cascade and eventually result in the endothelial injury. And thus all the complications related to diabetes sets in. So essentially it's the hyperglycemia which is the root cause for all the complications which we encounter in our patients, which is in the form of micro and macrovascular complications. So logically and of course scientifically also, the good glycemic control is of paramount importance in delaying or preventing the diabetic complications. So if you don't target this hit hard, hit early principle, you will end up in that. So the Occam's razor is, I'm sure all of you are aware, where the simplest solution is the best one when you have 2-3 options. And the evidence is for that, which I'm going to show you. You can see the major adverse CV outcomes in type 2 diabetes is these are the 4-point maze which we do in clinical trials. Look at all these death from CV, death from coronary artery disease, hospitalization of cardiovascular diseases. These are the basic points which we touch upon. So the impact of CVOTs, which changed the paradigm of type 2 diabetes management, have created a focus on organ protection with less emphasis on the glycemic control. That is where I am trying to argue that evidence is effective with respect to the SGLT2 and GLP-1s. The individuals with are at high risk of CVD, we are trying to target. That is where we are missing the bus. And the CVOTs included participants with CVD or multiple CVD risk factors, and the outcome cannot be generalized to all the people of diabetes. And that is where people with diabetes we need to look at as the holistic picture, where these trials which are targeted, I am part of many of these global landmark trials, and there you need the outcome cannot be generalized to the wider diabetic population in routine clinical practice. And that's where we see most of them, 70% of them with the risk factors, and 30% will have this established CV disease where you cannot generalize this. So what do the studies show? You can see the intensive glycemic control has been the leading preventive aspect in all these trials which are landmark like UKPDS, ACCORD, ADVANCE and VADT. And that is where we come that our experience with these, especially the UKPDS, we have the data now with 4,500 patients where the increased incidence rates with higher A1C, you can see very clearly correlate with the microvascular complications which are seen at any endpoint related to diabetes, or MI or microvascular complications are almost proportional to linearly with your A1C levels. And UKPDS, this slide I'm sure all of you would have seen about 100 times so far, every 1% drop in A1C. That means we're talking about the glycemia. If you bring down 1% of A1C, look at the advantages you get with respect to the complications of the diabetes related, whether it is stroke, MI, heart failure, or the amputation or microvascular complications. Now we have 10 years data, and we have 24 years post-trial data, which are consistent and persistent legacy effects. You can see the red highlighted 2021, which talks about the any diabetes related endpoint, MI, microvascular or all-cause mortality are clearly shown even beyond 24 hours after intervention has been stopped. And that's the best part. You have that legacy effect still continuing. The target was A1C to prevent the complications, not that you look at the complication and treat a patient. So the primary prevention segment, what we need to target is nothing but glycemia. Similarly, the advanced which 11,000 plus patients, 5 years follow-up, intensive arm clearly showed the reduced incidence of combined major macrovascular. Advance was the first trial which showed the macrovascular benefits as far as the complications are concerned. And this is a Swedish national registry, 2.7 lakhs odd patients, 5.7 year median follow-up, clearly showed the HbA1c outside target range was the strongest predictor of stroke and MI. So it is always been the A1C and the glycemia where we are trying to target and take it forward. And what do the most guidelines talk about? The A1C of less than 7 or around 7, what the guidelines talk about. And of course, about the FPS, 80 to 130 is what the range adequate to meet that HbA1c goal of 7% and below. And when you see the A1C reduction, it is that the root cause for the significant reduction in the risk of major adverse cardiovascular events in all these trials, whether it's GLP-1s, the SGLT2s or the DPP-4, the MACE events are proportional to the A1C reduction. So the guidelines with respect to the TIR again clearly talks about 7%, where the 70% time in range correlates with your A1C of 7%. And remember, whenever there is hyperglycemia, the symptoms of frequent urination, thirst, fatigue, etc. are only controlled with respect to the reduction in the glycemia, that is blood glucose levels. So the whole school of thought still holds good that achieving optimal sugar levels directly reduces the risk of diabetes related complications, immediate relief from hyperglycemia related symptoms, improving daily functioning and overall well-being of the patient is taken care when you target at the earliest stage. So the question comes, what about the holistic approach? See, as I said earlier, the impact of CVOTs in the management paradigm during the last few decades, the evidence has been emerged from these SGLT2s and GLP-1s, and these results have created a paradigm shift to focus on organ protection and less emphasis on the glycemic control, of course. So the unintended consequences of many individuals with poor glycemic control but without complications is the target population, the study populations which we see in the CVOTs. And these, you can see the cohorts of CVOTs, SGLT2 where the intense glycemic control RCTs, they're clearly the cohort with intensive glycemic target are more representative in your routine clinical practice, where the baseline CVD rates, the disease duration of the trials were all better in the intensive glucose RCTs versus your CVOTs which are seen with the SGLT2s and the GLP-1s. So the results may not be generalizable to a wider audience what you extrapolate from these CVOTs. Now the major point, you can see the right hand blue circle there. Can anybody tell what is that written there in that blue circle on the right hand, superolateral on the right side? What is written there? Yes. So that talks about the clinical inertia. I have blown up that. It says to avoid clinical inertia, reassess and modify treatment regularly. That is what it is shown there, and which most of us read. And unfortunately, even in that slide, the ADAC consensus, it has been so small that we have inertia to read that. None of us read that. So this is what is the inertia which we tend to talk about, and to the failure to advance therapy or to de-intensify the therapy when appropriate to do so, which most of us don't do. Quickly, you can see in this decade of 1999 to 2018, the trends in diabetes management in the US, so-called advanced country with respect to the glycemia, blood pressure, lipids, and all risk. I have 2 more minutes. I'll close it by that. There is no advancement as far as the benefits are concerned. And this is a Discover study which talks about the patients who are not being escalated to second line therapy in a timely manner. Look at across the globe, we are also in the same boat. There's nothing. Median time to treatment intensification, you can see I've compared trials. And what I want you to concentrate in this, the treatment adherence is poor in people with diabetes when it comes to the OADs, the GLP-1s or insulins. Very important point to note, and read that footnote now. People who are new to diabetes therapy were 61% less likely to be adherent compared with those continuing therapy. So that's important. And if you extrapolate the results of the leader, you can see the CV benefits of Lira. We were part of the leader study, and the CV benefits of Lira were mediated by the reduction in the A1C. And in CVOTs of DPP4, GLP-1, SGLT2, this risk reduction of non-fatal stroke was entirely attributed to the glycemic control. As I said earlier, not everyone have CVD. Only 1/3 of the population have CVD. The remaining can focus on achieving and maintaining the glucose control, which itself can control your CVD risk factors and prevent the complications. And of course, the legacy benefits of multiple risk factors. If you see this slide, the longest evidence we have with respect to the glucose of 44 years, BP of 10 years experience, lipids 18, and the multiple risk factors we have 21 years. So the longest evidence we have for the organ protection is nothing but your hyperglycemia. So therefore, optimal glycemic control remains a definitive solution in most of our patients in routine clinical practice. So in diabetics, you aim at intensive glucose therapy at a personalized level, of course, especially relevant for many patients who do not have complications. Holistic patient care is a context dependent, it is individualized. And of course, delaying glycemic control with various strategies might worsen outcomes. And we know the early preventive interventions and tight glycemic control is associated with the long-term benefits. And a number of interventions can help early glycemic control. Key issue is individualizing therapies and interventions. And my talk with this conclusion of hyperglycemia is the main cause of diabetic related complications. Glycemic control brings direct reduction of risk of these complications. Hence, the glycemic control remains paramount in diabetes management. Thank you very much for patient hearing.
Moving further, we have the next esteemed speaker who is going to talk about the other side of the session is Dr. Suresh Damodaran from Coimbatore. Is an immediate past Vice President of Endocrine Society of India, Executive Council Member of Endocrine Society of Tamil Nadu. He is a founder president of Diabetes Endocrine Thyroid Society Coimbatore and currently appointed as member of editorial board of BJD, that is a British Journal of Diabetes. He has not a number of awards and honors on his name and various publication to his name. Over to you, sir.
Good morning, everyone. Thank you very much for the wonderful opportunity. And to my good friend, apart from talking the second half for me and also checking the visual acuity of people and some IQ challenging for people. Apart from that, I think he's almost convinced everyone that the holistic approach is much better. Now, the paramount this thing, I don't think so. I think the glucose-centric attitude has changed a lot time ago during our training days, more than 2008. Now, this is a complex disorder, and if you just go with the sugar alone, there are a lot of ways the sugar can go up. You can't, if you're not addressing all these issues, it's going to be no-brainer that the control will be there, but you won't achieve what you want to achieve. So, well beyond the glycemic control alone, Dr. Srinivasa Murthy is very keen of strict glycemic control, but I think you have to reduce the complications. I'm sure you all will agree for that. And he said there is no heart disease at all. When you hear him nicely, I think. But the risk is extremely high. 54. When you're diagnosed to be a diabetic, you're diagnosed to have a heart disease. Now, this tells you the heart disease is a cause of death in most of the people of the type 2, and it's most common cause of death of type 2. You see almost 86% of the atherosclerotic cardiovascular disease account for that, and then it is accountable for almost 50% of the death. That is a huge number. So if you don't address this issue and just go for glucose alone, you know what you will achieve. So one in with the 3 people with the diabetic cardiovascular disease and glucose lowering treatment with proven cardiovascular benefit that Dr. Srinivasa Murthy has mentioned, and also 9 out of 10 people have established cardiovascular and ASCVD. So majority is not being managed to the treatment level adequately, which we all agree. And the inertia he's shown, that is there lacking for the whole lot of holistic treatment. So CVD and obesity, which is the key part. He was mentioning is part of leader and other things. Main advantages are all through the benefit of the weight loss. So if you look at it, 86% people with living are obese or overweight, and there are overlapping factors. So PCOS, you get sleep apnea, there are quite a lot of other things. So, but the challenge is the race, ethnicity. We are on the wrong side of it, being Asian, and physical inactivity is coming up with all our digitalization and being more remote working. So the blood pressure, dyslipidemia, and weight. So decrease of 10 millimeters of mercury, it can improve quite a lot, and then controlling the lipids and controlling the weight all will help. So Indian picture, if you see, the risk factors are quite high, and we almost die very early, 10 to 20 years, and the people of diabetes have cardiovascular. This is all known to us very well, but we have to address it, and that's the whole point. So management strategies, how do you do it? And as I said, in 2008, during our training days, guys, can you speak a bit lower? So 2008, the A1C was lower, the better, and that was the days. And now, after that itself, it is changed. Lower the better, but without side effects. When the rosiglitazone and quite a lot of other drugs of sulfonylurea, insulin, and the 2019 now, we have to target every single thing. Blood pressure, LDL, glucose raising, and with the safety and efficacy. So weight loss, does it have an effect? Absolutely, it does have an effect, and the impact with the CVD markers, the whole lot improve with weight loss alone. So for example, the triglyceride and the good cholesterol all will have a good impact with the weight loss. So almost 5% of the body weight leading to associated the improvement of risk factors with 48% of hazard ratio over 10 years. So correct management of your diabetes is very, very important. Maintaining ABCs, regular follow-up, healthy weights, stop smoking, all this is going to be a key. So A is not only for A1C, but I think we got A, B, C now, blood pressure and also cholesterol, all has to be, and we have moved from A to ABC. That's a long time ago. Now managing ABC is very, very important, following the diabetes plan, and also now apps and AI has come into the management. So if you can integrate all that, then you will have a better holistic approach, so that the health economics, if you like, will improve significantly. So blood pressure, blood lipids, glucose, and when you reduce the BMI, it has got all this benefits. So we need to target not only the sugar but LSM, and then blood pressure control, and then dyslipidemia. So if you reduce even a small amount, it's got a huge benefit. And we've discussed, Dr. Srinivasmurthy discussed about the guidelines. Yes, if you look at the guidelines, has shifted from the holistic management of sugar alone, and they really want everything to be addressed. So you can see in the very well seen this thing, not in a tiny corner where you can't see. You can see more of incretin and SGLT2s, and quite a lot of other integration with not only glycemic management but glycemic management with the weight loss. And the same thing applies to the ESC European guidelines in the even drug naive patient to go for GLP-1 and SGLT2 inhibitors. Even for, as I mentioned, for GLP-1 is recommended for drug naive patients from ASCVD and high risk patients, because most of them will have asymptomatic cardiovascular disease, and these people will benefit hugely from these group of drugs. And then if you look at the future treatments as well, there are a lot of treatments is coming in that direction where you'll have a multiple benefits. So ESC guidelines also shifted. Agents like GLP-1 has recommended along with metformin in high risk patients. So multifactorial approach is going to be the key, and impact of the diabetic medication also plays a role. So we want to select a drug that has got impact not only for sugar control. I mean, what is the point in having an expensive insulin once daily or once weekly or once monthly, whatever, but if you have a glycemic control but you have a weight gain along with it, it is going to be a challenge. So you select the right agents properly, and then receives the diabetic treatment with CVD benefit, and it is going to be amazing for the patient. So it is time to apply for the evidence, where even for the clinical presentation and then going for screening and prognosis, even for the MACE, you go for the holistic treatment. So not only A1C alone, this should not be the focus on health. We have to focus on all other things, thinking about the complication and the health economics that will drive the patient down. So we need to target each one, blood pressure, cholesterol, and along with the A1C, not only just A1C alone. So look at Dr. Srinivasmurthy. I think if he goes for a really expensive insulin and target the blood sugar and only brings the blood sugar back, then buy any 2 burgers but pay for both. You have to pay for both. It's very expensive. But on the other hand, like Indian mentality, I think we all like buy one get one free. So selected drugs where it can provide where it can provide a proper this thing. I think it can provide a benefit of not only for diabetes control, but the blood pressure and the whole lot. You can get the benefits of buy one get three free. Thank you very much.
I think I'm going to take a quick show of hands. How many of you all are with Srinivas? I'm not going to put my hands up. So, and how many of you all are with Suresh? So the Trump is winning, huh? So let me give you my perspective of this. So the debate is about glucose control. And glucose control matters in the first decade of a diabetic's life. That is the first take home. In the first decade of a diabetic's life, if you hit hard, hit early, and we are only restricting to type 2 diabetes. If you hit hard, hit early, and I think both the speakers directly, indirectly said the same. If you hit hard, hit early, glycemic control matters. Slower the better. And there is a whole concept of metabolic memory and legacy effect. So clearly, if you see a person living with diabetes in the first decade, you are generating by poor glucose control a bad legacy and burden of complications. So hit hard, hit early, and if your A1C is below 6.5 or 7 in the first decade of a diabetic's life, without hypoglycemia, without weight gain, and if there are cardiorenal benefits, I think that's ideal, and that's what the evidence base says. That's what the mega trials or the randomized RCTs say. If you are beyond a decade, decade and a half, okay, we had in the first decade of the 21st century, 3 mega trials, VADT, Accord and Advance, which showed no major benefit or maybe some harm or hurt if you did a tight glycemic control. So that's where the challenge was. So that is that if the duration of diabetes is more than 10 or 20 years, you may not acquire the benefit of tight glycemic control in terms of metabolic memory. Blood pressure doesn't have that metabolic memory or legacy effect. Neither has the macrovascular group. So clearly, I think the message is hit hard, hit early. This whole debate is moving from glucose-centric approach to fat-centric approach, CV, renal, kidney, liver and brain. Okay. But what is driving this? Is it academic science? Is it standard of care? Or is it market forces and regulatory? My take is very clear. I don't have any duality and conflict of interest. It is purely driven by pharmaceutical industry and market forces. They may be my friends in the industry sitting here, but this is clearly driven by them. Because despite of all the new advances, 10 years back, every 7 seconds one person was dying with diabetes. Now every 5% one person is dying with diabetes. So despite of all these new drugs which we have got, we still have people dying due to diabetes, and that has not changed even 1 anna. Okay. So I just spoke below. I don't know how many of you all were in my talk. Dr. Venkat Narayan gave a Kelly West lecture a couple of years back, and he says that the story of these mega trials and glucose control in type 2 diabetes is winning the battle and losing the war. So what are we doing? We are growing the industry, using more drugs, winning short battles of glucose control. Srinivas, don't feel bad, you are my good friend. Okay, but we are losing the war in the big game. And you know what are the defaulters? Defaulters are access, affordability and adherence. Diabetes India, if you see the logo here, it is written availability, affordability and access. That's why I didn't want to have any slides. And if you see those 3 A's, if you do not maintain constant availability of your medications, whatever may be the medications of A, B, C, D, E, F, do not maintain an affordable access and adhere to it, the guidance, and don't see your doctor who's a qualified doctor like all of you, you will not get to target, you will not get outcomes. So today we are an outcome driven space, and if you want people living with diabetes to live longer, to live healthier, to live complication free and live happier, you need to have treatment protocols which are affordable, accessible, available, and the person should adhere and be motivated to take it regularly. If that doesn't happen, we don't get to goal, and if we don't get to goal, we are back to square one. So this is the current truth of modern medicine in type 2 diabetes space. So once again, I appeal to all of you that idea of this debate was that glucose control does matter in the first decade of a diabetic's life. Hit hard, hit early. In second, third decade, it may not matter. So probably both are winners in their own way. There are mega trials backing it up. But the crux of the issue is adherence, affordability, accessibility, and availability. And today we are in an era where beyond glucose, we have other outcomes like cardiovascular outcomes, renal outcomes, liver outcomes, and even brain outcomes. So a normal person living with diabetes, type 2 diabetes, used to probably live a decade less than other people. Are we able to change that lifespan of a diabetic with these cutting edge drugs? And are we able to live longer with them without complications? And I think that data is available. So I think glucose control does matter. The price of glucose control, which DCCT showed us, is hypoglycemia. Because DCCT had almost 60 events, which was 2 to 3-fold higher incidence of hypoglycemia in type 1 population. Of course, that you will say it's a type 1 population. And therefore, the price you paid in the addict cohort, though there was again memory imprinting, was hypoglycemia. And you know, Bob Bigersi just showed a very nice paper of virtual DCCT, where DCCT time there was SMBG and urine monitoring. But he showed that if you did AI driven virtual CGM and did a virtual DCCT, you could still get that same effect. So I think what we need to recognize are 3 take-home points. Glucose control in the first decade in type 2 diabetes matter. In the second or third decade, it may not matter. Beyond glucose, you need to take care of B, blood pressure, C, LDL cholesterol. So, you know, he showed the Trump equation, my good friend Suresh from Coimbatore. And he was a little naughty with that. Okay, which is not pardonable. But anyway, God bless you. And then beyond A, B and C, you need diet, you need exercise, you need feed care. And finally, I know I have a minute and a half left. We all need to have a singular commitment that we need health outcomes and happiness outcomes. And we need adherence. So I think we are probably, as Charles Dickens said, in best of times and worst of times. Best of times because we have a problem of plenty. We also are in best of times because we have drugs which are affordable and available. But in worst of times is because we don't have time for educating, motivating and empowering people living with diabetes. And because we are not able, or our team are not able to give adequate time to our patients, we are not able to get them to targets long term. And that is why we are winning the battle and losing the war. Thank you so much.